So I'm going to talk a little bit about the diagnosis. You've heard about diagnostic tests in the radio Simon Lovestone story. I mean, I sit on the welcome panel that responds to these papers and does the media bit. There was vitamins. Vitamin D was mentioned recently. We saw the benzodiazepine overview this morning. It comes out all the time. The controversial topic of screening, because Mr. Obama has everybody in the United States screening, and then any of you have followed the BMJ debate between sort of Alistair Burns and a group of us, and then another lot of people around the screening issue, and just a slight amount on prevention. So that's the light touch, and hopefully you'll find it kind of interesting from your own personal perspective. Diagnosis largely made in secondary care. I think the dog can tell if the patient's demented, so definitely it's possible in primary care. There's no problem there. Like somebody said earlier, it's about listening. It's all in the story. And it usually the diagnosis we make, and I'll illustrate this, is an impairment in cognition, usually memory, sufficient to cause a functional deficit, right? Now the question is at what level of function that is. Is it finances, driving? You know, it's not basic activities of daily living. Certainly that's well done. So the historical perspective, and it's just where we move to, because the attempt is now there to use biomarkers or additional tests we can, because you will say in the community, it's not like diabetes, it's not like heart failure where you have a BNP, you don't have a marker, what are you diagnosing, boys and girls? And you've got scans that all show atrophy and white matter. And it isn't normal for age. That's the one thing about it. You know, I remember seeing a scan reported in a 62-year-old, atrophy and white matter, and the GP was alert enough to send that patient to me and said, I didn't think in a 62-year-old you got that much white matter and atrophy. It's totally right, totally right. So what we do is you do the initial, never mind all this garbage, the initial identification of a dementia syndrome, and then you look, and I'm talking principally about Alzheimer's disease. Everybody in this room has Alzheimer's disease. What you don't have is Alzheimer's dementia. What we don't know in the main is what converts you from Alzheimer's disease to Alzheimer's dementia. So you need a memory disorder, and you also need an impairment in one cognition, so orientation, whatever, using an MMSE or GP cog, you can test that. But it must interfere with social function or activities of daily living, and that's what we use to diagnose a sort of a dementia syndrome. And the ADL, activities of daily living impairment, defines the threshold, and that's where we've been in terms of the diagnostic criteria. Now, that was 1984. That's 30 years ago, so things have moved on quite considerably. The use of neuroimaging is now very, very, mandatory almost in terms of certainly vascular dementia. But we're not just talking about a diagnosis of exclusion, we're actually talking about a diagnosis that we can make based on the information we have. So this is what you now have. So MRI changes, and those are medial temporal lobe mostly. In vascular dementia and Alzheimer's disease, the hippocampus will atrophy, so that's not characteristic. You'll get it in both conditions. But if you can get MRI scanning done, of course you'd say this is pie in the sky, because I know a lot of my colleagues in old-age psychiatry in Britain don't do an image. We image everybody. And as I say, that's, I think, where things are going, because the cost of imaging is coming down radically, even FDG glucose PET scanning, which is what we can use and what you will get, and is one of the new proposed biomarkers that I'll talk about, so you can show hypometabolism or hypoperfusion, usually anterior cingulate, precuneus, temporal parietal lobes. Lewy body will show up with occipital lobe dysfunction, and in a PET scan, it's better than a SPECT scan in my view for diagnosing frontotemporal dementia. But it is costly, but the price is probably halved in the last year. And of course, we don't do lumbar puncture in the United Kingdom. If you turned up with a cognitive problem in Scandinavia or Germany, they'd stick a needle in your back. So there's a culture. If we were going to do that, there'd be a whole cultural issue in terms of that. We'll talk about that in a minute. So these are the proposed new diagnostic criteria for an Alzheimer's disease situation. Now, they're still to be evaluated, but it's just to give you an idea of where we're going so we can be more definitive in what we say. So A plus B, and I'm going to illustrate B, C, D, and E down the line. So A, clearly you've got a memory impairment. So it's gradual, it's progressive, and it's there for over 6 months. So if somebody comes into the surgery with a 3-month history, and you've got 7 minutes, you can explain to them why you're going to bring them back. Unless it's started suddenly and it's rapidly declining, that's the only situation where you'd refer in. When you test it, there's an objective evidence, and it doesn't sort of normalise that type of thing there. So those aren't different much to the previous criteria, and associated with other cognitive changes as time goes on. What are the B, C, D, and E? So they're basically what I've illustrated to you. So if you can, You know, Najee Tabbitt, who's University of Brighton, some of you maybe know Najee, that's the routine image Najee does, is an MRI scan of brain in everybody. So most people will have a CT in my situation. But MRI, you look at the, you can score it, but basically the neuroimaging people, or even the non-neuroimaging, the general radiologist can probably look at that. So you would look at the regions of interest. So it would be hippocampus and medial temporal lobe. Abnormal cerebrospinal fluid biomarker, I'll show you a slide of this, but if you do cerebrospinal fluid, the amyloid actually in cerebrospinal fluid goes down. It's the hallmark pathology in the brain. So it's low, tau is increased. You can measure ratios, so you can look at one, this, or combinations of the three. So in Scandinavia and Germany, they'll do that. The United States, that's not done. Australia, it's not done. Far East, it's not done. It is invasive. If we were to suddenly start lumbar puncturing, all the patients came to the memory clinic, we'd see nobody. So there are issues around that, but there is a biomarker. The problem is it hadn't been standardized globally, but you can see where we're headed. And then the other thing is specific functional neuroimaging with PET, and this is glucose. It's not the amyloid ligands that we can use. The amyloid ligands more or less tell you what I've told you already. You've got Alzheimer's disease in your brain because you've increased uptake of amyloid, but it's not going to tell me whether your dementia is present or not. We find this very, very useful in that it doesn't tell any lies. If you have problems in your cingulate precuneus, it's more than just subtle, because the neurologist, the radio specialist will not, or the neurospecialist won't be categorical on just slight changes, but you're on the slope. And I think that's what we mean by a biomarker, and that's the one that we find patients most accept. They don't have to sit in an MRI scan for 30 minutes, although the coils now will let you do it in 20. So basically, that's quite acceptable to older patients. We would use it at the moment where, the likes of everybody, supposing somebody in this room came along to my clinic with complaining of a slight memory loss with a wee bit of functional abnormality, the PET scan will tell me whether you're going or not, because there's no other neuropsychological test will tell me that. So if you want to know chapter and verse, this is as good as you'll get. And then the other one is, of course, and you'll know this from the family history, will be if there's a mutation, usually presenile in one within the immediate family, and usually the whole family cascades over, and they've got dementia in their 40s and their 50s. So that's a definitive criteria. Because at the moment, the most definitive criteria of diagnosis is post-mortem still. But this is where we're moving to. So you've got a 4-stage kind of situation will emerge, and you will see this happening in the not too distant future. First of all, dementia is present. We are looking to determine now more definitively that it's mostly Alzheimer's disease, because they will probably have, if they're older, CT, white matter change and atrophy. And you're getting an increased level of certainty, and then we look to the biomarker probability. I'll talk to those in a minute or two. So there are these reports in the papers about we've got the diagnostic test. So to put it in context, these are sort of things you're looking at. So this is a sort of schema. We think this is what happens. So preclinical, then you've got this mild cognitive impairment condition, which is not normal aging, not dementia, but you're probably, in the vast majority of these people, will convert. In our clinic, it's 15% per annum. The meta-analysis show it's 10% per annum. So these are people who have significant cognitive problems, but yet can manage everything very, very well. So they wouldn't meet the criteria for dementia syndrome. So the amyloid starts to accumulate first. That can be detected in the cerebrospinal fluid or using a specific amyloid ligand in PET. Then you get the brown as a synaptic dysfunction. So this is where your neurons are starting to be affected by initially oligomers, but then amyloid plaque. That's where the FDG PET comes in. So you can see this is all going on preclinically. You get the tau-mediated problem starts to kick in, that cell death here. And at this stage, then people are starting to show some level of cognitive impairment. And then as time goes on, you're going to see this loss of volume. So the MRI is actually fairly late in the process. FDG PET and the ligands are much earlier if you're going to use them. Cognitive function goes, and then the clinical function appears. So we see people, at this stage, very, very early in the vast majority of situations now in the United Kingdom, but it's really the end stage of a process that's been going on for quite some time. Now, to talk biomarkers, you've heard a bit about them today, should actually detect the fundamental features. So that's amyloid and tau at some level. Should be more than 80%, specificity more than 80%, and you should be able to distinguish from Alzheimer's disease to other dementias, mostly frontotemporal and Lewy body. Reliable, reproducible, non-invasive, simple and cheap. So that's what you're aiming for. And could capture, if you have a treatment for a clinical trial, and the objective of this is to get the right people into clinical trials, because I think we've maybe not done so well at that. Predict who will convert from this mild cognitive impairment to dementia or Alzheimer's disease, and provide the earliest intervention. And that's the big aim, really, when you're looking at this. I've mentioned these things, but it's like diabetes. The blood test is the holy grail, so that's what the recent papers would have looked at. So I'll just show you we're a wee bit away from that, despite what you hear in Radio 4 and on the press. So just to give you an example, so proteomics is about proteins in the blood. So somebody produced a paper, and actually they looked at a group of Alzheimer's and they looked at a group of controls, and they clearly were different in the proteins that they measured. They said, aha, this proteomic test, i.e. not one protein, but a clump of several, if you identify them here, will distinguish your control from your Alzheimer's disease. So then somebody went to validate. And this is the validation. So the blue is controls, and the red is that other crosses are Alzheimer's disease. Do you think, is there a differentiation there? No. So done in a separate group with total validation. Then to look at Alzheimer's disease from other dementias, can you see a distinguishing feature there? No. So the validation did not show that this proteomic approach was working. So what we have had most recently, this is, you'd say, 2014, and this is the one that made the news, and everybody's going on here with the diagnostic test. So that's the summary conclusion there. And it was a big study. It was done in several centres across Europe. If it was the test, right? So I knew it wasn't, because it wasn't in the Lancet. It wasn't in the New England Journal. You know what I mean? It's been through those places. It's been reviewed. It's in a decent journal, Alzheimer's and dementia. And it has good value. So a clump of 16 proteins, and you get a panel of 10 proteins predicted the people who would convert from mild cognitive impairment to an Alzheimer's diagnosis with pretty good accuracy, sensitivity, and specificity. The authors did make the point, like the proteomics, it's going to need validated. And that's where we are with that test. What it does show you, though, is of those 10 proteins, I mean, I was involved in the genome-wide scan, and the pathway analysis has showed us what, for example, cholesterol and inflammation pathways are all important. What it does show us is a number of these proteins do map onto that work. So what it does is it advances the whole science significantly, so you actually learn a lot more about the pathophysiological process. And let's face it, this is a blood test. So there is some kind of transference here between the brain and the blood. And we will evolve to some sort of blood test, but it won't be one. It'll be a panel. If you follow me, it'll be a panel and a pattern. And again, that's called metabolomics. We'll deliver on that. So that's that sorted. So what about vitamins, diet, and nutrition? I don't know what any of you are taking in the audience. We could do a straw poll to prevent your Alzheimer's, because that's the big thing you worry about. It's the one I would worry about. Heart attack, no, I'll probably survive that. If I get diabetes, Simon will sort me out, Mike will sort out my bones. But basically, I don't want a stroke, and I don't want, because a stroke will be a disabling stroke. Not right? Stroke's great if it kills you. Do you know what I mean? Or you make a full recovery. But the big fear is what I'm talking about. And it's not taboo with us. I mean, I think it has to. I mean, David Cameron's prioritised it. So what about vitamins, diet, and nutrition? So this is the Mediterranean diet that I'm sure in this audience you all consume. Some of you even look Mediterranean. You've eaten so much of it. That's no bad thing, but the Mediterranean diet, what is it? So this is how it was defined. I thought I would put this in. So plant-based foods. So you're all eating grass. Fresh fruit, olive oil, and I just smear myself in olive oil going on holidays and hope that the tan will improve. See, it's light touch, this. Dairy products, cheese and yogurt. Fish, moderate amounts. Too much of the oily fish, the dietitians would say, is not good for you, actually. 0 to 4 eggs, red meat, wine in low to moderate amounts. And you've got this kind of fat. But it's the overall constituent of the thing, isn't that right? Are there any dietitians in the audience? No? Unlikely to be, but that's what they'll say. It's all about diet. It's not about feeding yourself vitamins. So there is a noise around this is the key thing. I mean, if you're on the slippery slope, it's not maybe that you'll avoid conversion totally, but this is adherence to Mediterranean diet. I maybe showed this slide here before a couple of years ago. This shows that the better you adhere to a Mediterranean diet. You can read that for yourself. It's an analysis, includes all the risk factors that we know about. So it's a good study. There is a lower risk of converting from a mild cognitive impairment to an Alzheimer's disease. So Mediterranean diet does seem, when you're on the slippery slope, to delay that, right? But that's the Mediterranean diet, and it's a retrospective study. It hasn't been tested in a prospective study, i.e. placebo versus people eating a Mediterranean diet for a couple of years. But it's been replicated in another study, and it looks pretty good data. Now, this is a list with, as I say, I've told you about the oysters. Now, the oysters are good for you because they're zinc, you know, and zinc is also a major constituent of sperm, I think. Isn't that right? So that's why people eat oysters. The almonds is vitamin E. The green tea, well, I've listed some of these things here, but it's all based on antioxidants and mop-up of that sort of thing. So you've got the blueberries, and those are flavonoids, and basically they do have been shown to help this. Omega-3s do reduce amyloid pathology in mice. Those that have big feeds of curry all the time are hanging into the turmeric, and there's studies going on with turmeric. It's the curcumin, and basically it has these properties in animal models. The green tea, this is the polyphenol stuff. It is actually epigallocatechin 3 gallate, according to the Daily Mail. But EGCG is good. Antioxidant, anti-inflammatory. Red wine is the resveratrol. And it's really extract of red wine. It's very antioxidant, really. And then you've got ginkgo, which is more of the flavonoids, and it is antioxidant. The tomatoes, I mean, men should eat tomatoes anyway for the prostate cancer, you know. Amla is a very high sugar. Someone will clarify for me, but it's a preparation. I think it's Indian derivation. I mean, meat and the vitamin E, and then the fruits and vegetables, vitamin A. So when it comes to those are the things that have been tried individually that, you know, they haven't worked much. Some studies are ongoing. When you look at people with Alzheimer's disease versus controls, I've looked at the data on micronutrients. So selenium's down, vitamin C and E is down. Transitional metals we're not sure about, but the zinc, the copper, the iron in your brain are quite significant. We're still trying to work out what those do. Vitamin D, I mean, that's the big noise recently. You know, if your diet's low in vitamin D, you know, it's reduced in Alzheimer's disease, and your risk of Alzheimer's disease higher. B-complex vitamins, there's a bit of mixed data. Omega-3s, mixed data. But when it comes to selenium, there's been no studies. Vitamin C and E have been trialled, no effect. Transitional metals not trialled. Vitamin D, there has been a study of intervention, no effect. B-complex, some plus, some negative. I mean, there's really no consensus there. And the omega-3s, again, is plus or minus. But you will get people, I've said to Simon earlier, a couple of people, I had one person who was consulting this dietitian, and there were about 100 products they were buying, some of which I'd never heard of. So the daughter was poisoning her mother, was my view. But I don't know how much they were paying. Do you know, this is about the appropriate use of money, because you're going to pay this, really. And I mean, the bottom line is, you and I know, like preventing stroke and heart attack is about blood sugar, it's about cholesterol, it's about faster risk factors, blood pressure and all. It's not one, my blood pressure versus your cholesterol. You know, it's not that. And this is the same thing here, hence the Mediterranean diet sort of thing. So hopefully that puts it in context. You do have nutritional interventions that are specific. This is a combination of B12 and folic acid, and I think acetylcysteine. I don't think it's available here, but you might get your patients asking about these things because they're on the internet. And I've had patients come back from the United States on Axona. So what happens is your brain works on glucose mainly, but it also works on free fatty acids. So you can use free fatty acid supplementation as a way to rack up the amount of stuff goes on in your brain. So that's what Axona is. They have limited they've evidence that shows a cognitive improvement after 45 days in Alzheimer's disease. The problem is 1 in 4 people can't take it because of the tummy problems. So that's the runs and a lot of problems like that. That's free fatty acids for you. The one that is available here, and again, people have to pay for this, is the Suvinade. It works on a different principle. Again, I'm just showing these things in case patients ask about it. Brain specific. So these are things that are thought to form neurons. And then you've got all this thrown in as well, and selenium. They have a clinical trial program. It's designed to support the synapses, and actually there's more data on this than there is in Axona, and it's actually safe. So if people want to pay £3.50 a day, and you can't prescribe it. You know, they do need a medical recommendation, but it's up to them. But I mean, I would rather they took something where there's a minimal data set. There's some effect on memory here. This is 24 weeks, active treatment versus control. 12 weeks, there's a, you know, this always happens in Alzheimer's studies. But these are people who are treatment naive, and the drug, the food supplement is food for special medical purposes. It seemed to only work on mild disease. But the interesting thing is, at the end of 24 weeks, you either stay on the stuff if you've got it, or if you didn't get it, you go on it, and there's a continued signal on an aspect of cognition. It's not the full NTB. But there's a signal there, whereas if you're buying vitamin C, vitamin B, and some of the health food places do charge a fortune for these things, at least we know this is safe. The commonest side effect is it improves your skin condition. It's a bit like stopping smoking, maybe, as we heard earlier on. But look, you know, I mean, in Australia, when I was there a couple of years ago visiting Prof, I think they were eating, you know, it was something like $50 to $70 a month Australians pay for nutritional supplementation, and a lot of it is just money down the drain. So it's where you want to put your pound. So screening, so there's this big debate now about screening, and the Royal College of General Practitioners have been involved, and there's been a series of articles, and then there's people writing the BMJ, Margaret, whatever her name is, writes about it. This is the World Alzheimer's Report. Now, timeline of disease progression. So onset of neuropathology is way back. Then we get predictive biomarkers. So we're not, as I said to you, just quite there yet. So we need to bear that in mind. Then you get the onset of cognitive decline, onset of disability, and then you get, you know, things have advanced pretty far on. So people would say at the moment, in a large number of places, folk are turning up late. So it's a late stage diagnosis. What I think is happening in a lot of centres in the United Kingdom, certainly in Belfast, is a timely diagnosis. So people do accept if they have a memory problem. It is a concern. They commonly say they're worried about it. We either tell them you have or you haven't. If you have, we put you in the nice recommended treatments that now cost nothing. And basically that stabilises the situation. But we're not screening, actually. If you got the current available technology, so we've maybe moved a wee bit this way because we would do PET scanning in these people with MCI, so we can detect at a very, very early stage that those areas of the brain are knocked off. Now, it doesn't always mean a diagnosis because it isn't a diagnostic test, but taken in context with a clinical picture, it could be. So we will soon move to this, and we will be testing those new biomarker criteria. You would only do this if you've actually got the definitive biomarker, which we don't have yet. So, I mean, would you want to know at age 50 that, you know, here's a biomarker that tells you you're going to have Alzheimer's disease is where you're headed? You know, but we're not there yet. So, clearly that's what's going to happen. Now, in terms of screening, you know, you need to have an effective treatment is the ultimate. So, you know, we have treatments for Alzheimer's disease, and NICE recommends them, but it's not like blood pressure where you can show a significant reduction in stroke. So in terms of screening criteria, definitively, you couldn't argue for a national screening program. Obama's done that, but you couldn't argue for it, and I don't think any of us are saying that. So we're in this kind of opportunistic situation here, where if patients come forward, well, yes, we'll look at them, but that's the situation. We're not. You could look for in diabetes, for example, Simon. You probably well know with the risks there. That's an enriched population. There's a very high risk of Alzheimer's disease and dementia there. You could go in there, and probably you'd find a heck of a lot of it. In the renal failure, you know, the dialysis population, if you screen that, you know, thinking of advanced care plans and all this sort of thing, cognitive testing shows up usually a lot of problems there, but those aren't done. But what I suppose we do, you know, if we get a patient into the ward and they're not doing something properly, they may have a delirium, which will settle, but the OTs will come and say, they're kind of sat there, not interested. Well, okay, they could be depressed, but then the OTs often do the cognitive testing, because, you know, executive function, getting up and going, that sort of thing, is all to do with, you know, they will look at cognitively what are they like, and then that's how we're finding them sometimes if they're not diagnosed. But these are all interlinked. So that's why we look for it in the ward situation. I mean, you can't ignore it.